واتكلم بس النهارده على هذه العلاقه الابديه. احنا بنطلب كتير من دكاتره الاطفال حاجات ساعات صعبه جدا. دكتور عمر قال ان لا، هو ما ينفعش ادي دكتور الاطفال البيبي وخلاص وكده وهو دي مسؤوليته. انا لازم اساعده. وهي الفكره دلوقتي في المساعده في حته سبيسيفيك جدا اللي هي البري تيرم ليبر. عشان نعرف بس اهميه البري تيرم ليبر دي، عايز اقول كوت من هو ما بيلفش ليه؟ ما بي doesn't move ليه؟ هو دكتور عمر جاب سيره كتاب اسمه مونرو كير، اللي هو الكتاب بتاعنا اللي بنعتبره مهم قوي 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 في الاوبستاتريكس في الدليفري. بس انا عايز اقول على حته معينه لفتت نظري جدا في كتاب ويليامز، اللي هو بنعتبره الريفرنس بتاعنا قوي، مهم جدا لحد دلوقتي. بيقول ايه؟ It is generally admitted that exists in the medulla a center for uterine contractions which can be stimulated by an excess of carbon dioxide in the blood, by anemia, and the presence of various toxic substances. And it seems highly probable that the frequency of premature labor in cases of renal insufficiency and eclampsia may be due to the action of metabolic poisons upon the center. ده اللي قاله جون ويتريدج ويليامز سنة 1903 في الفيرست edition of Williams. PTL, preterm labor, was not mentioned as a stand-alone topic except in the 13th edition in 1966, totaling only 3 sentences citing isoxaprine as a tocolytic. In contrast, present-day research now produce more than 3,000 articles annually. عشان تعرفوا بس التحضير البرزنتيشن ده كان صعب ازاي. 3000 article annually about preterm birth. But despite the efforts elucidating the biology of human parturition and the subsequent efforts to prevent preterm birth remain elusive. Complications for preterm birth are a primary cause of neonatal death and short-term morbidities and long-term disabilities. And of course, you know better than me about these complications, with huge economic, psychological, and social costs. By definition, preterm birth is defined as delivery before 37 completed weeks. Subdivisions vary among organizations, and these subdivisions مهمة because they guide the management protocols according to the gestational age. Because neonatal care had advanced tremendously, the threshold of viability, which is the lower limits of fetal maturation compatible with extrauterine survival, has been reassessed, and currently it lies between 20 and 26 weeks gestation. We have 4 direct causes of preterm labor: spontaneous unexplained PTL with intact membranes, idiopathic preterm premature rupture of the membranes, intentional delivery, and multifetal gestation, together with other less important contributing factors. Is it predictable? Is preterm labor predictable? We wish, يا ريت يعني. However, progressively shorter cervical canals assessed by vaginal ultrasound are associated with increased rates of preterm birth. And the American College of Obstetricians and Gynecologists recommend screening women with prior preterm labor and find it reasonable for women with no prior preterm labor. أنا ما أعرفش في مصر إذا كان كل الأوبستريشنز بيعملوا screening ولا لأ، بس at least إن في a good proportion of obstetricians بيعملوا كده، بالذات مع second trimester screening. فبس يعني دي لو كانت يعني تبقى أكتر من كده أكيد هتفرق كتير. Adding biomarkers to prediction is of no benefit and not recommended. طب is it preventable? Again, we wish. Prevention of preterm birth remains an elusive goal, difficult to achieve. However, prevention in selected populations may be achievable. Cervical cerclage. You know all, of course, كلكم عارفين يعني ايه cervical cerclage. هي للاسف بتتعمل كده روتينلي كده دلوقتي، بس هي لها 3 specific indications انها تتعمل which would really benefit the patient if it's there. Recurrent second trimester pregnancy loss diagnosed with cervical insufficiency، ودي بيكون لها history معين اللي هو second trimester rupture of the membranes followed by very fast delivery of a live infant and almost painless. ودي بنعرفها retrospectively لما البيشنت تيجي تقول لنا ده حصل كذا وكذا وكذا، يبقى this patient will benefit from cervical cerclage. The second one indication is rescue cerclage, and the third is cerclage for short cervices. What is rescue cerclage? An emergency cerclage. اللي هي بنعتبرها emergency cerclage. في meta-analysis of 11 studies found a significant prolongation of pregnancy and reduction of perinatal mortality after an emergency cerclage for cervical dilatation, not effacement, but dilatation. And the administration of indomethacin and antibiotics increased the percentage of women who did not give birth within the following 4 weeks. What about the instance of cerclage in sonographically short cervix? The benefit appears to be directly related to whether this woman had a history of preterm labor or not. In those without prior preterm labor, cerclage for a sonographically detected short cervix alone offers no benefit. In contrast, women with prior preterm labor with sonographic short cervix may benefit. And the ASO concluded, American Society concluded that in women with a singleton pregnancy, prior spontaneous preterm birth, cervical length less than 25 millimeters, cerclage placement may be considered versus progesterone therapy. What about progestogens for prevention? احنا عارفين ان in most mammals progesterone withdrawal initiates parturition, probably functionally through reduced progesterone receptor activity. And conceptually, it follows that progesterone administration may prevent preterm labor. This hypothesis has stimulated several studies on 17-hydroxyprogesterone caproate and vaginal progesterone in women with various risk factors for PTL. But is it beneficial? Well, it depends on which meta-analysis you read. In one large trial, women with prior preterm labor were assigned to either 17-hydroxyprogesterone caproate or placebo, and recurrence of preterm birth rates was significantly less in the progestogen group, but this trial was questioned due to asymmetry in the risks of recurrence. In another large multi-center randomized trial called the Prolonged trial, which was conducted over a period of 9 years, progesterone was not effective in preventing recurrent preterm birth. In a recent meta-analysis by the EPIC group, the investigators concluded that both vaginal progesterone and 17-hydroxyprogesterone reduced preterm birth in high-risk singleton pregnancies, and currently the American College and the Society of Maternal Fetal Medicine recommend continued use of progesterone for prevention of recurrent PTL in women with singleton pregnancies. What about progestogens in short cervices? 3 randomized trials are at the center of whether progesterone therapy should be used in women without prior preterm labor, but who have a short cervix. In the first trial, the rate of preterm birth was significantly reduced in the progesterone group. Same results were shown in the second trial. However, the third trial didn't show any significant difference. And because of the preliminary encouraging results, the multicenter optimum study was carried out in women with short cervices receiving vaginal progesterone versus placebo. Contrary to earlier reports, vaginal progesterone was not associated with a lower risk of preterm birth or composite neonatal adverse outcomes. And in children at 2 years of age, vaginal progesterone had no long-term benefits or harm. Thus, evidence remains conflicting as to the efficacy of progesterone across various indications, and virtually all evidence supporting progestogen's use for specific indications can be challenged in some way. I believe in Egypt we give progesterone كده دي سواء في indication or not indication، حتى بيسموه في مصر مثبت الحمل. هو اسمه مشهور في مصر باسم مثبت الحمل. نيجي على المانجمنت of preterm labor. The goal of management is always to reduce neonatal mortality, short-term morbidity, and long-term disability. And this may be achieved through 4 main treatment modalities. Of course, I'm sure you all know about them. اللي هم tocolysis, corticosteroid therapy, antimicrobial therapy, and magnesium sulfate for neuroprotection. For tocolysis, these are the drugs commonly prescribed for tocolysis. Of all of them, calcium channel blockers like nifedipine appears to be the safest and most commonly used. None of the drugs is completely effective in stopping preterm labor. It only stops contraction temporarily, but rarely prevented. And according to the American Society, it has concluded that tocolytic agents do not markedly prolong gestation, but may delay delivery in some women for up to 48 hours. This may allow in utero transport to an obstetrical center with higher level neonatal care and permit time for a single course of corticosteroid therapy. And because the perinatal outcomes in preterm neonates are generally good after 34 weeks, most do not recommend use of tocolysis after 34 weeks. Corticosteroid therapy. You know that Liggins and Howie were the first to evaluate corticosteroids to treat women with preterm labor. Corticosteroid therapy was effective in lowering the incidence of respiratory distress syndrome, neonatal mortality rates if birth was delayed for at least 24 hours after initiation of betamethasone. And this was followed by many studies. And in 1995, a National Institutes of Health Consensus Development Conference panel recommended corticosteroids for fetal lung maturation in threatened preterm birth. So corticosteroids is خلاص الموضوع انتهى. They are all beneficial. But the recommendations are a single course of corticosteroids is currently recommended for women between 24 and 34 weeks gestation, which is the early preterm period, and who are at risk for delivery within the 7 days. For pregnancies at 23 weeks at risk of delivery within 7 days, a single course of corticosteroids may be considered. And a single course of corticosteroids may be considered in pregnancies between 34 and 37 weeks. What about the periviable period? Administration of corticosteroids during the periviable period is linked to parental decisions regarding resuscitations and should be considered in that context. This means that if the patient or the woman does not want aggressive resuscitation, I shouldn't give corticosteroids because this necessitates neonatal care and might not be يعني appropriate for the patients بالذات ان هي حاجه مكلفه جدا. Should we give repeated courses? A single course of corticosteroids has been compared with repeated courses for lung maturation in 2 major randomized trials. Both found that repeated courses reduce neonatal respiratory distress, but the long-term consequences were different. And currently, the American College recommends a single course only and not repeated courses. But this is different. Rescue courses is different. A rescue course refers to administration of a second corticosteroid dose when delivery becomes imminent and more than 7 days have elapsed since the last dose. And most societies recommend or consider a rescue course, but the gestational age differs between different societies. Betamethasone and dexamethasone are equally effective. And because treatment for less than 24 hours may be beneficial, the American College recommends that a first dose of antenatal corticosteroids be administered regardless of the ability to complete additional doses before delivery. Antimicrobial therapy differs between PTL with intact membranes and those with ruptured membranes. For PTL with intact membranes, results of studies have been disappointing when they were given to arrest preterm birth. In this Cochrane systematic review, antibiotic prophylaxis given to women with intact membranes did not reduce preterm birth rates or affect other clinically important short-term outcomes. However, rates of short and longer-term harms were higher for children of mothers exposed to antibiotics. And antibiotic administration is not recommended in PTL with intact membranes without signs of infection. With ruptured membranes, various antibiotics have been evaluated to delay preterm delivery. And in this meta-analysis of 13 randomized trials evaluating antibiotics for PROM before 35 weeks, 3 benefits were identified. Fewer women developed chorioamnionitis, fewer newborns developed sepsis, and pregnancy was more often prolonged in women given antibiotics. And in a maternal fetal medicine unit network trial, antimicrobial treated women had significantly fewer newborns with respiratory distress, RDS, necrotizing enterocolitis, and composite adverse outcomes. And the latency period was also significantly longer, 50% in the treated group versus 25% in the placebo group. Importantly, antibiotics given for women with PROM had no effect on the health of children at the age of 7 years. These are the antibiotics recommended in general: ampicillins, ampicillin sulbactam, erythromycin, azithromycin, but amoxicillin clavulinate is not recommended because it has been blamed for increased incidence of necrotizing enterocolitis. And the current recommendations, which states that according to the outcome of the Oracle 2 studies, it is not recommended to give antimicrobial therapy for women with PTL and intact membranes unless required for GBS prophylaxis. And the ESOG recommends giving the previously mentioned antibiotic therapy ampicillins regimens for women with PROM, and also recommends that antimicrobial therapy period to be at least a 7 days period for prolongation of the latency period. What about magnesium sulfate? It has been shown that very low birth weight neonates whose mothers were treated with magnesium sulfate for tocolysis or preeclampsia were found to have a reduced incidence of cerebral palsy at 3 years. And because of this, randomized trials were designed to investigate this hypothesis. In one trial, women at risk of delivery before 30 weeks gestation were given magnesium sulfate or placebo. Magnesium sulfate exposure was associated with lower rates of neonatal death and cerebral palsy. However, the study was not sufficiently powered. But more convincing evidence came from the randomized maternal fetal medicine unit network study, where a 2 years assessment period showed a significant reduction in the rate of moderate or severe cerebral palsy in the magnesium-treated group. And nowadays, all societies recommend that magnesium sulfate be administered intravenously for fetal neuroprotection to patients less than 32 weeks gestation at imminent risk of preterm birth. So in summary, those were in the preterm labor with intact membranes. Glucolysis is given to delay pregnancy for 24 to 48 hours, giving time for corticosteroid therapy and to enhance lung maturity, and given time to transfer to tertiary neonatal centers. Magnesium sulfate also is given for neuroprotection. This is in preterm labor with intact membranes. For premature rupture of the membranes, أنا مش عارف إذا كانت التيبل دي باينة ولا لأ قوي، بس this table, this general scheme shown in this table can guide management. For 37 weeks gestation or older, no, you have to deliver the patient. Recommendation is to deliver with GBS prophylaxis. In the late preterm gestation period, expectant management or delivery. If you go for expectant management, you need neonatal consultation and consider a single course of corticosteroids and GBS prophylaxis together with treatment of any intraamniotic infection. If it's there, you have to deliver. But in the early preterm period, expectant management is recommended. But if there's any maternal indication for delivery, you have to deliver. Single course of corticosteroids, GBS screening, antibiotic recommendation to prolong latency, and for pregnancies less than 32 weeks, magnesium sulfate for neuroprotection. Currently, the American College of Obstetricians and Gynecologists cannot make firm recommendations. أنا فاضلي دقيقة واحدة بس. Clearly, gestational age is an important consideration. At 24 to 34 weeks, expected management in the absence of non-reassuring fetal status, clinical chorioamnitis, or placental abrasion is recommended. At 34 weeks to 37 weeks, delivery was once recommended, but now is considered reasonable to offer expected management. Expected management should not go beyond 37 weeks. For those with PROM, there's special considerations to be shown. With PROM in pregnancies before 26 weeks, the volume of amniotic fluid remaining has prognostic importance, and current rates of pulmonary hypoplasia with PROM before 24 weeks among surviving neonates can be as high as 30%. Further, when contemplating early expectant management, oligohydramnios and resultant limb compression deformities are influencing considerations. You have to treat chorioamnionitis, of course. So how can the obstetrician help? Is to predict, prevent, properly diagnose those who are in labor and not send them home because of misdiagnosis, management according to the guidelines in general, but use proper judgment in selected cases. In labor and delivery, you have to go for continuous electronic fetal monitoring, GBS prophylaxis, episiotomy is still controversial, avoid instrumental delivery, especially vacuum extraction, and recruit staff proficient in resuscitative procedures in tertiary care centers. Cesarean delivery has been recommended by some societies for preterm labor, but most of the cases it's reserved for usual obstetric indication. أنا آسف طولت عليكم جدا، بس موضوع preterm labor موضوع طويل جدا جدا. حاولت ألمه في 20 minutes، بس يظهر برضه زاد عن 20 minutes. Thank you very much.
Thank you, Professor Ehab. دلوقتي طبعا بنبارك للدكتوره ولاء والدكتور شريف انواري على نجاح المؤتمر وعلى النخبه الجميله من طب الاطفال، جايبه كل عظماء طب الاطفال والنساء والتوليد، ويا رب دايما بالتوفيق وعقبال كل سنه. دلوقتي يسعدني ان انا اقدم